Good morning, everybody. I would like to invite you to the ophthalmic surgery parallel session at the 2:22. The title of our presentation is Telemedicine in Ophthalmology. And given the couple of years that we have, we've certainly all been given a catalyst to try and fine-tune this platform for everyday use in our practices. I'm very pleased to invite three wonderful speakers, Aoife Doyle and Tomas Burke and Christine Goodchild, all of whom have a ophthalmology. So I'd like to just give some instruction. Is first and foremost, there's a live Q&A forum where if you have questions, I would like you to submit them through that portal. And secondly, the presenter chat forum is really for commentary. The outline of our talks will essentially be 20 minutes per presenter with a 5-minute Q&A following each individual presentation, followed by live Q&A for approximately 15 minutes at the end. So with that, I'm going to open it to Mr. Donal Brosnahan, my co-chair, to introduce our first speaker.
Hello, good morning. So it gives me great pleasure to introduce Aoife Doyle, who even prior to COVID had done a lot of pioneering work on running virtual clinics, and this was accelerated during COVID, and she's going to speak to us about some of the novel and innovative ways in which we can manage the patients virtually. And so I'd like to welcome Aoife Doyle. Thanks.
Hi, thanks Donal, and thanks Kathryn for inviting me to speak at this meeting. I'm just going to go straight in now to sharing the slides here. So just check that those have appeared there. So can I just check, are the slides visible? Yeah.
Yes, they're visible. Yeah.
They're visible. Okay, thanks. So so we have had, as Donal said, a bit of experience even prior to COVID at the Eye and Ear Hospital in remote medicine and electronic health initiatives, and this is something that's very that glaucoma is very suitable for, and there's some experience on this already coming from the UK. So we thankfully have a very large glaucoma team at the Eye and Ear Hospital, led by myself and Jeremy O'Connor as the consultants, and also we have Dr. Maurice Marcus, who's been working for us long term as an ophthalmologist. But we have an excellent team of trainees, including more recently the rotating higher medical trainees in training, and our advanced nurse practitioner, Ciara Liston, has been really instrumental in helping us to set up all of our electronic record originally for the glaucoma clinic and our virtual clinic setup. Also, all our staff nurses are trained to work in our glaucoma assessment clinic and to take, as well as doing fields, which all staff nurses do. Over 50% of the nurses are trained to take photographs, check IOP, and take a brief history from patients. So remote clinics in the UK have been active for quite some time in glaucoma, and in a survey in 2017, 50% of glaucoma specialists at that point already had active clinics, and another 21% were planning them. And a College of Ophthalmology audit was carried out back in 2017, so well prior to COVID, and they found that 22 people per month were suffering severe permanent visual loss just as a result of delayed follow-up care. And the most common diagnosis in this group was glaucoma. There's no national audit in Ireland, but we know that the delays in accessing care in Ireland are much greater than in the UK system, and they are known to be increasing, probably you could almost say exponentially as well since COVID. We did carry out a series of audits at the Eye and Ear, and in this I think we're unlikely to be different to other units, as we do have a well-staffed glaucoma department. We found that a lot of patients who had delayed care were showing progression, about 30% requiring treatment intervention in one short audit over a month of patients who were delayed in their follow-up. We looked at further audits of patients who'd been waiting a long time in 2017, and we're finding at that stage a mean delay in appointment time of 18 months with a range from 17 to 23, and 40% of those would have fallen into a high-risk category. And by 2019, we had almost 1,000 patients on a waiting list waiting for follow-up care. So this was the impetus to move on with the planned virtual glaucoma clinics. Also, if you look at the projections for increasing numbers of patients requiring glaucoma care, you can see from UK epidemiological modelling that there's expected to be a huge increase from 2015 to 2035 of up to 44% in glaucoma care. And presumably that's taking into account as some of the pre-existing suspects of ocular hypertensions actually convert to glaucoma. They, for some, don't seem to be increasing by quite as much. In the Republic of Ireland, our prevalence projections were based on CSO statistics from 2016 in the increasing populations of all of these different age categories. And they show again a potential increase. If you take glaucoma and glaucoma suspects, you can come up with between 7 and 10% of patients in the over 75 category needing care of some sort. The actual true glaucoma rates are not as high. Our Roscommon Eye study from 1993 probably still contains some very relevant data, except that the percentage of people in the older population categories is actually increasing. But in terms of what prevalence of glaucoma you could expect in different age groups, you can see that glaucoma POAG itself ranges from 1.35 to 2.53, but there's a large number of ocular hypertension patients, glaucoma suspects, and actually the secondary glaucomas and the chronic angle closure glaucomas, which take up an awful lot of our care in consultant clinics and an awful lot of surgical care, are actually only a very small percentage of the population. Glaucoma also accounts for 12% on the blind register, and it is a profound form of blindness because to be registered you have to have a visual field below 20 degrees. Generally, we can consider it affecting 2% of the population over 40 and 3% of the population over 70. So with the aging population, we can expect greater and greater numbers requiring care and monitoring. We carried out a rapid improvement event through a Lean Health initiative with our Ireland East Hospital Group back in early 2020, and before we even envisaged that COVID was going to come along. And at that stage, we had already established our clinic at the Eye and Ear, but we put together the figures for the two hospitals, and there were very long waiting lists in both hospitals put together. That's the Eye and Ear and the Mater Hospital. We know that then after the first wave of COVID, we had an estimated 2,500 patients overdue for review by late or June of 2020. The national waiting list, to give an idea of the way it has increased, went from 30,800 on waiting lists in 2016 to 47,000 by 2019. Maybe some of our panelists might have more up-to-date figures on what it is since COVID. So the virtual clinic model at the Eye and Ear Hospital was set up in November of 2018. The patients were transferred from our clinical nurse specialist clinic, and that was Ciara Liston at that stage, and she was instrumental in helping us set up this clinic and setting up MediSite for use before it was in general use around the hospital. All the staff, a number of staff nurses, about 8 of them, were trained to work in this clinic with 3 sessions a week, and they would take a short history from patients. One nurse would carry out fields, the other would take a short history with 4 questions, and measure Goldman tonometry, take a cow photograph and the visual fields. And it was set up, at the time, it was set up in such a way that it could be run either on site or remotely, with thinking ahead at that point into the future when we might move some of these clinics out into the community. Some units also add OCT. We felt that, given the cost of an OCT machine and the fact of moving patients backwards and forwards into a general queue over in the main outpatients, that this would delay the flow of patients in our unit anyway. And whereas we felt that disc imaging is an absolute necessity, and this is reflected in units around the UK, and certainly visual field testing is essential. The follow-up afterwards would be in the main outpatient department with the consultants, or with, at that time, the clinical nurse specialist, depending on the complexity of the problem. So we had, in the first 10 months, 112 clinical sessions. We went from small numbers as the staff were training up to much larger numbers. So we reached our peak around about June and July of that year. And for some reason, it was a little bit of a fall off, probably because we were, after transferring all the patients from the nurse specialist clinic, we were on an active recruitment, trying to encourage people to refer patients out of the main clinics around the hospital. And there's an idea that we saw 944 patients in the first 10 months. The cannot attend and did not attend rate was about 8%, which was not too high. And the 40 were discharged. So there was a 5% discharge rate and 12% referred on. But this was probably a little higher than our referral rate is now, mainly because this was the first 10 months of the clinic. So some patients may have been transferred in there inappropriately. So the ophthalmology waiting list then was hit further by COVID-19, as we know, and from March 2020 to June 2020, most clinics were stopped due to the need to prevent infection. Patients didn't want to come to the hospital, and the need for social distancing. And probably in the eye and ear, we got back on to, because we're a dedicated eye hospital, we were able to get back seeing patients a little sooner. But even at that, we were really only seeing patients from about mid-May onwards. So there had been a significant gap in care, and a lot of cancelled clinics, which everybody would be very familiar with in all specialties all over the country. And when we went back to working, of course, it was in a more limited fashion due to the need for social distancing of the patients when they did come for appointments. The more routine the care was, the less likely the patients were to be seen based on the criteria. So we had 2,500 patients on the waiting list between the two hospitals, and the delays were due to all the reduced numbers of patients seen, and, as I said, the capacity curtailment. So we brought together the group that had attended the initial rapid improvement event in January, which the great plans we had were all scuppered by COVID. So together with Colin O'Brien and Anne-Marie Keown from IHG and Emma Smith, who helped us implement it, as well as a very large team, including our patient service, director of nursing, IT input, we secured the use of the City West facility, which at that stage was generally unused. This was prior to vaccination, so it was a testing centre. And of course, there was the unit with the beds, which was underutilised. So we had the use of some of the tents and decided to proceed with this drive-through IOP clinic. And this remote gathering of patient information was already ongoing in Belfast, and we were aware of this, and this worked very well for them. They have an excellent glaucoma unit run by a number of consultants, but Angela Knox has put in a very good system of virtual clinics there as well. And it's based in the Shankill Road with a very large car park. So they were actually able to do their drive-through clinics in their own car park, and it was very popular with the patients. Since that, there are studies that we weren't aware of at the time published on other drive-through clinics, but this particular one is interesting from Birmingham, where they showed that eHealth alone versus eHealth with IOP measurements showed a much higher intervention rate if the pressure was measured. So we're very, very dependent on patient measurements in glaucoma, and running e-clinics online by just phoning the patients is not very satisfactory, other than possibly being able to sort out issues with irritation related to drops and maybe changing patients from one type of drop to another in order to prevent that. But for the most part, we need measurements, and we need a series of measurements over time. So we put together our patients and our teams, and we had two staff members out in the City West facility. We transferred all of the patients from the existing glaucoma assessment or the virtual review clinic at the Eye and Ear, and we also screened charts of patients who were overdue for visits. At the Mater, this was mainly screening of charts. At the Eye and Ear, it was a joint thing of screening charts. And then later on during the course of it, our charts had been uploaded onto the electronic system, so we were able to screen them through DocMan and allocate a task for the patient as to where they were to be referred to. So this made it more streamlined from our point of view. And the criteria for transfer were mainly patients with ocular hypertension, primary open-angle glaucoma, normal tension glaucoma, and later we relaxed the criteria to include all of the long waiters. So the patients had phone calls to explain. This was very time consuming, but our DNA rate would have been very high had we not explained what it was about. But most of them were very happy with it. And when they arrived, they had a questionnaire asking them had there been any change in their eye health or in their general health, and how they were getting on with their drops. Were they adhering to their drops? And any new medications that they had commenced as well. So this is the questions that we put in our standard virtual clinic. And this was done remotely at the City West facility with the use of laptops. Our IT department were extremely helpful, and some went out on site as well to set this up. And the information, as soon as the clinic was over, was stored and available for review by the team. So as we know, with eye care tonometry, Goldman is actually the gold standard, but eye care is quicker and more comfortable and can be done while the patient sits in their car. The studies show no significant difference, or only plus or minus 3 millimeters of mercury in 90% of measurements within the normal range of IOP, but they do become less accurate as you get into the higher range of IOP above 21. So the accuracy starts to wane a little bit, but there's still no significant difference in 80% of patients in that group. So over the course of that 1 year, we saw 672 patients. The matter, we saw 534 from the INEAR, and this was really due to the benefit of already having an electronic record in place, which made it easier to identify and refer patients. So we worked alongside each other for the first 6 months and then continued it with the INEAR patients for a further 6 months. And the mean drive through IOP with eye care was 19.4 plus or minus 0.6. And that was significantly higher than the pre and post City West measurements of 16.3 and 17.1. So it was generally a little higher, and these are the main diagnostic categories. And you can see the majority falling into primary open angle disc suspects and ocular hypertension. And this is where the patients, out of the first 420 patients, 25% of whom had a subsequent follow-up when we looked at this data. A lot of them ended up going back to the virtual clinic for subsequent reviews, the doctor-led clinic and the nurse-led clinic. So whilst there were 84 patients out of 420 referred to the doctor's clinic, this large number of patients were able to be seen, and they did not all require urgent requirement. This 0 to 3 months correlates almost exactly with those who came promptly to the doctor-led clinic. So all of these other patients were able to go down our other pathways. The interventions were change of drops, laser, and surgery. And we didn't need this for too many. If you look at the overall group, there was a significant number of medication changes in 53 patients, or 18% of the patients, but a small number needing laser and a smaller number again needing surgery, and a small percentage of patients were actually discharged at that point. So we saw 300 out of 301 patients who've had follow-up. We did publish our results on this particular group of patients, and you can see that a lot of them had an eye care below 21, 69 had 21 to 25, and 37 had a measurement over 30. And at this point, the correlation with between eye care and GAT starts to become wider, and it's less reliable, but it's still a red flag for a problem if it's over 30, and it's good to bring the patients back. So the ocular hypertension patients were more likely to have high IOP, understandably, because a lot of them would be left off treatment because they have healthy discs and fields, and they were only viewed in the INEAR if their pressure was 4 millimeters or more higher than their previous measurement, and we had the benefit of having access to this through the EPR. So the study limitations would include the fact that not all patients, of course, have yet had fields, although now we have a large proportion of our patients have returned, and we'll soon be at the end of the year after the last patient was seen. Out of 200 patients with full field reviews, there have been about 7% have been seen to progress, and that's between 2 visits, so between their previous virtual care clinic and their current virtual care clinic review. So that's not much higher. You know, that's with patients who had a drive-through IOP clinic in the meantime. So there wasn't much progression on the patients that we deemed stable on the eye care measurement. The future role for the drive-through clinics might be as a treatment addition, you know, when you just after you've put patients on medications and they've had a full visit with the doctor or with our ANP in our new patient clinic, they could possibly go for a drive-through measurement for their first visit or following an SLT, and then possibly for low risks or suspects on every alternate visit. And this is something we'll have a clearer picture of when we've analysed more of our longer term data. I'm just going to quickly skip over the fields because I don't want to run over time. I want to leave some time for questions and just give a brief overview of where we're moving to next. We're trying to transfer our virtual care model into the community, and it's a similar model to the assessment clinic at the Eye and Ear, and the links have been set up between the CH07 clinic and the Eye and Ear Hospital. Out there, the tests are taken by optometrists rather than by staff nurses, as in our unit, and these optometrists are gradually upskilling and hopefully may be able to work at the level of a clinical nurse specialist or even an ANP after a number of years. And they're reviewed by the medical ophthalmologist. So that's the current team, is 2 optometrists and a consultant. And there are also some starting to train their consultants now, or their optometrists in CH06. And these are just our first set of patients who were transferred out. And it's by the same process that we set up for City West, whereby we screen the patients either by consultant or by the medical HMT or by our ANP as to whether they're suitable. And we refer them out for the clinic out there. Now, the rate of referral to the consultant ophthalmologist is higher for 2 reasons. That's these are where the patients actually end up. And the main reason for this currently is that we're currently screening charts of patients who've been waiting 3 or 4 years, some of them, for care. So they're overdue for care. So a higher percentage than usual have to be seen in a clinic with the consultant ophthalmologist, but she's hoping that when the optometrists have reached the level of CNS, they'll be able to see some of the more minor issues like drop irritation, coexisting cataract, and the percentage of patients having to be seen by the consultant ophthalmologist will be lower. But you can see there's a very low percentage of patients being referred back to the clinic at the Eye and Ear, and we'd expect that to get a bit lower as we're gradually transferring our patients from their catchment area, from our own virtual clinic, out to them, and the complexity of the patients being seen in the community will be much lower. So any questions?
I think Kathryn is, yeah.
That was really, really comprehensive, and it's lovely to see the transfer of that whole process into the community where it ideally lies. I guess the question is, do you see this evolving sort of nationally, and what would the barriers to that be, Aoife, do you think?
I think it does need to evolve nationally. It's very, it's based on a similar model to most of the models in the UK. I think the main barrier to care is the lack of an electronic patient record. I mean, we've made a lot of progress on that at the Eye and Ear over the last number of years. And as the GLAUCOMA team, we initially did start using it ourselves, even within the hospital for that. So I think that is the main barrier, actually. It's a shared care record between the main hospital hub and the community is absolutely essential. And then the second one will be acquiring staff and training them up to the level that's needed. But there's good work going on that already. And whilst the optometrists are currently doing, what staff grade nurses will be doing in the Eye and Ear, you would expect with their background training that it shouldn't take them too long to upgrade to the equivalent of CNS. So they'd be able to do some of the more, the more basic area, like managing coexisting cataract, dry eyes, knowing when patients need to be listed, etc. So reducing the amount of patients having to come back for full consultant review.
Donal, you have a question there?
Yeah, Aoife, thanks very much. And it's huge progress really in the right direction, and based on good science and good practice, good for the patient, to be seen locally. And so just going on, just it's my own ignorance, I suppose. What about patients measuring their own pressure? I mean, I remember seeing bits and pieces about it. Are there any developments on that? I mean, that'd be the equivalent of the drive-through, really, wouldn't it?
Yeah, there's a new thing, there's a portable eye care that patients can use for self-use. There has been a little bit of work done on that, and some patients are quite good at it, others not quite, maybe not quite as good. It's a fairly expensive gadget as well. But that is, that's another possibility, as the patients would measure their own IOP, or at least take some of their IOP measurements and then come back, because it does have to be correlated with the Goldman tonometer. And then you can see from the results as well that it's not quite as accurate as the Goldman. So, you could end up, I suppose you could also end up with a certain amount of noise as well, and concern over high measurements. You probably want to have a series of higher measurements before you'd necessarily react or respond to it. So I think it's something that's likely to be included in patient care for some patients, or for suitable patients. It probably won't be the only thing. And similarly, I think Kathryn was interested in fields, which I skipped over there because I didn't want to be running into other people's time. But visual field testing is going to be very challenging. And there's not very much done yet, but there are some studies done particularly by David Crabb's team over in the UK, where they do a form of visual field, a thing called eye catcher, which is easier to carry out in the home environment. And that is, the patient kind of presses a button when they see a light appearing in a location on the screen while they're focusing on a central fixation light. So that seems to correlate quite well with fields, but the first published studies are on very limited numbers of very motivated patients. And it's felt that in terms of what we know about monitoring glaucoma progression over fields, it'll probably be used alongside visual field testing, but won't necessarily take over from it. But I think, home measurements of both fields and IOP could certainly allow us to maybe reduce the number of patient visits, possibly by half, and particularly in this low risk cohort. And if you see the numbers, if we could reduce it by half, there are a number of visits that we'd be making huge progress.
Yeah, when you think about it, even if in my own experience, not as a glaucoma specialist, but the patients, it's usually a large change in the field that prompts action. It's not a subtle change, either that they've missed appointments or missed testing. And then they suddenly crop up and you realize actually there's a huge change in the field. So even a less accurate field than a Humphrey is going to pick up those sort of changes maybe earlier, and be feasible, rather than looking at really very subtle changes, which you're probably just going to change medication rather than,
Yeah, although that would depend a little bit. I think paracentral changes do tend to push us to move faster. But you're right, particularly in older patients with slower progression rates. I mean, you could see that we tend to establish the progression rate in the first 2 years, really, after seeing a patient who has a visual field defect at the time of presentation. So if they're kind of slow progressors with mild defects, the kind of patients that are gone into our virtual clinics, or if they're patients with no visual field defects, it would seem perfectly reasonable to be allocating them to those group, to home testing, because there's such a low rate, as you said, there's just such a low rate of progression in that group anyway. I think probably the patients with advanced field loss, or very significant or paracentral defects, will probably end up needing to be monitored more closely.
Maybe sorry to hog it all, but so I mean, you could, everything that's that's done in the virtual clinic could be done in optometry, just for the sake of argument, could be done by an optometrist in an optometric, high street practice.
Good, that's another way to do it.
I think the UK has sort of gone more that way, because they don't have a community's ophthalmic service. Well, they haven't historically. So they've gone that way. It might be. Well, I don't know. What do you think of?
It's the way to getting out to more patients, and they've already started in Northern Ireland, where their system is just a little different to the UK. They've already started sending all of their ocular hypertension patients to registered and linked optometry practices across Northern Ireland, because the OHT are the absolute lowest risk group. So they've moved all of the ocular hypertensives out of the hospital system completely into optometry practices. And I suppose that's where you get the greatest, like the patients are delighted with the transfer to Tele, as you know, and they're really pleased with it being close to home. But that's where you get the greatest coverage, I suppose, is if it's with their optometrist.
Okay, well, that was really enlightening and obviously the way forward. Thank you so much for that, Aoife. Now we're next going to move over to Tomas Burke, and Tomas is a consultant ophthalmologist in the Mater Hospital. And again, he has a keen interest in tele-ophthalmology and retinal disease. So I'll hand you over to Tomas now.
Thank you very much, Kathryn, and to Kathryn and Donal for inviting me today, and to the college for hosting this, and to you all for attending. As I said, my name is Tomas Burke. I'm a consultant in the Mater, and I'm going to speak a little bit, give more of an overview of kind of tele-ophthalmology and how it can be applied in retinal diseases. These are my disclosures, none of which are relevant to today's talk. I'm just going to chat a little bit about why imaging really facilitates tele-ophthalmology in retinal disease, and why tele-ophthalmology is needed in retinal disease, particularly given the burden of disease that we expect over the coming decades, what virtual clinics look like, and then to look at some future directions and applications. You know, tele-ophthalmology and telemedicine in general is thought the word comes from the old Greek word, which means from afar. And as Aoife has alluded to already, you know, there's been kind of a huge growth in telemedicine and its applications in ophthalmology, particularly over the last couple of years with COVID, but even before that, looking at kind of the research efforts in this over the last number of decades, we can see that that has increased in line, I suppose, with technological advancements. And really, I suppose, what do we hope to achieve with tele-ophthalmology? It's, you know, if we start off, we want to kind of empower our patients to have, you know, greater input in their care, and to ensure that patients are seen kind of by the right person in the right place at the right time. But of course, the place doesn't necessarily mean a physical space. It can also exist in a virtual setting, which may mean their home or somewhere closer to home, so that they don't have to come to the hospitalized service to access care in a timely fashion. The World Health Organization has kind of come out with some very comprehensive guidelines and aspirational thoughts and recommendations for how telemedicine really can be integrated into patients' lives, and really it's from the cradle to the grave, from kind of birth notification through to death certification, and then all of the interactions that patients have with healthcare along the way, that these can be performed, you know, in a digital or a tele mechanism. And so why is retina well placed to, I suppose, to make use of telemedicine, tele-ophthalmology? If we look particularly at kind of the common retinal diseases that we see, that I see certainly in the medical retina clinic, you know, we're very reliant on imaging, historically, of course, for documenting abnormalities that we find in patients' eyes, but then these have, with cross-sectional imaging, etc., you know, it has really aided us in allowing us to make diagnoses, to monitor disease progression, response to treatment, and ultimately to kind of discharge our patients, or to at least monitor them when they're over the acute treatment phase. And here we have some examples of imaging modalities that you're all very familiar with, I'm sure, the standard fundus photo, and then the ultra wide field imaging. Here, this is an example of the Optos image of a right eye, showing the health of the fundus. Cross-sectional imaging, of course, or OCT. No prizes for guessing there. There's some subretinal fluid and pigmented detachment, which suggests an active disease process. And then we also even have things like non-contrast angiography, such as OCT angiography in this case, demonstrating a choroidal neovascular membrane. I suppose different to glaucoma patients, patients who have particularly macular conditions, but also perhaps more widespread ophthalmic problems, they may be aware of symptoms such as reduced vision earlier in the disease course. You know, as Aoife was alluding to, you know, visual fields are important for monitoring patients who have an asymptomatic disease like glaucoma, but with conditions such as age-related macular degeneration or macular edema secondary to a vein occlusion, these patients will often notice that they have a reduction in vision, which will prompt them to attend their eye clinic, either at the time when they don't have a diagnosis, or if they're in, let's say, a stable phase of their disease treatment, they may notice a change in their visual acuity, blurring of vision, etc., which will prompt them to seek care. And that's something that we can make use of if we try to manage and monitor these patients in a way remote from the hospital eye service, for example. And the other thing, of course, which patients can be aware of distortion or scotomas in their central vision. We're all aware of the increasing burden of disease, and this is, you know, data from about 15 years ago, which looked at registrations with blindness in Ireland. And it's interesting that, you know, 3 of the 5 most common causes are retinal conditions, including age-related macular degeneration, diabetic retinopathy and retinitis pigmentosa. Glaucoma and cataract are there too. And given that we know that there's going to be that we have an aging population, we can expect that the demands to deliver care to our patients are only going to increase. And we're all unfortunately aware of headlines like this. And I suppose if we look at the per capita number of ophthalmologists in Ireland relative to the EU average, we can see that Ireland is kind of towards the bottom, towards the lower end of the league table. And as a result of that, it becomes difficult for us as individual ophthalmologists or as an ophthalmic community to meet the demand in terms of delivering timely care to our patients. And this issue, of course, has been exacerbated by the pandemic, but that has caused us really to look at new and novel ways of how we can assess and monitor our patients. I was going to have a question just so that I'm not doing all the work. This is one of the other retinal conditions that teleophthalmology has been utilised for. And I was going to ask a question, but I know Christine is going to be covering this most likely in her talk, so or touching on this. So this is an example of retinopathy of prematurity, which is another retinal condition for which teleophthalmology has been applied. So even prior to the pandemic, many units were running different types of what may be termed virtual clinics. Some people call these stable monitoring clinics or low-risk monitoring clinics, and they may have been for patients who maybe didn't require active treatment. So perhaps you would be monitoring your patients who had kind of high-risk dry age-related macular degeneration, or patients who have choroidal nevi and checking to see if they have any change over longitudinally. But really, as we've been able to utilize treatments, for example, now within the anti-VEGF era for the treatment of wet macular degeneration, virtual clinics had, even before the pandemic, been employed in an effort to try to titrate treatment relative to disease activity. So, and this you might term kind of asynchronous management of patients. So patients may be on a course of treatment on a treat and extend regime for wet macular degeneration, and then at intermittent time points, usually coinciding with an injection, they may have data collected about their clinical progress, such as visual acuity, symptomatology, and also fundus photography and OCT. And using that information, a clinical decision could have been made or can be made at a time point separate from when the information was collected. in an effort to determine the ongoing treatment regime for the patient. So that kind of work was already ongoing even prior to the pandemic, and has been employed in various units with varying I suppose, degrees of utility and varying widespread. With the pandemic, however, it really focused us to develop new ways of trying to reduce the attendances of our patients in hospital. And this was I'm sure you've all been familiar with questionnaires, etc., that were put together to try to guide the clinical questions, etc., and the information that needed to be gathered from our patients when we were trying to reduce the need for them to be attending hospital. This was a questionnaire / clinical form that we developed for patients in our uveitis service when I was working in Bristol prior to returning to Ireland, and it just tried to ensure that relevant clinical information was collected on our patients. And I suppose what this process taught us and taught me was that we really need to adapt the clinical information that we collect on our patients in a particular virtual clinic setting relative to the disease subtype. So what may work for a patient with age-related macular degeneration is not necessarily the type of information that we need to collect for patients who have, for example, posterior involving uveitis. And also different types of mechanisms for how we communicate with our patients, be they telephone or video, will vary depending on the disease subtype. And a lot of work has been done, particularly in the UK, looking at the outcomes and collecting data on the safety and efficacy of these kind of virtual clinic hubs, etc. And this data has been published to show that they're safe and effective and are suitable at identifying those patients who are at higher risk, who actually do need to be brought into the hospitalised service for additional follow-up, etc. I've been involved with an ongoing project with the Uveitis National Clinical Study Group, which is based in the UK, but it does cover Ireland too. And this was trying to identify patterns of harm in patients with uveitis over the course of the pandemic. And one of the points that we found kind of on an interim audit of the data that has been collected so far was that for that particular cohort of patients, that particular harms were more likely to be identified when patients eventually attended for face-to-face reviews, and that there were certainly gaps in the information that was collected in the virtual setting, albeit mostly via telephone consultation in these patients. And the idea was to try to develop more robust mechanisms for managing these patients going forward, particularly with rolling lockdowns, etc. A number of virtual or video consulting platforms have been rolled out, and in the UK we had access to Attend Anywhere, which is also available in certain centres here in Ireland via the HSE. And Ian Livingston, who is the National Tele Ophthalmology Lead based in Scotland, has some fantastic videos showing how a slit lamp which has been enabled with a camera can be the image which is acquired via the slit lamp can be screen shared with, so that, for example, person who is seen, for example, with a retinal tear or retinal detachment in a community optometrist, or at a further away ophthalmic centre where perhaps vitreoretinal surgery is not available, that this can be connected to the slit lamp. The slit lamp then is connected to the computer or an iPad, and that this can be shared with a consultant vitreoretinal specialist in a different centre. And they've had examples of patients who were able to be direct listed without having direct listed for vitreoretinal surgery without having to attend the main vitreoretinal centre prior to their cataract surgery. So it's some great, very exciting videos. In the Mater, we don't have access to Attend Anywhere, but we do have T-Pro, which those of you who work in the Mater or have worked there may be aware we use for dictating clinical letters, etc. But that also has the possibility to schedule video appointments with clinicians. And so you just go on to the portal, you enter the patient information, put in their email and their mobile phone number, and then they get a text message which has a link and the details of their appointment, and they can click on that link, and then that can screen share back to the ophthalmologist in the main eye centre. But it's important to note that, so as the ophthalmologist doesn't have to be in the main eye centre, they can carry out the consult anywhere as long as they have access to a mobile phone, because the app can be run through mobile phones with an appropriate Wi-Fi or 5G. So certainly possibilities to exploit that going forward. And that too also has the screen share function. So again, where screens can be attached to slit lamps, where slit lamps can be camera enabled, so that they're connected to either an iPad or computer. Those can be shared with the consultant for review. As we move, I suppose, as our treatment paradigms improve and as newer treatments become available for conditions, for example, age-related macular degeneration, the plan will be that hopefully we will be able to see our patients less regularly. So, for example, I'm going to be principal investigator on port delivery system trial at the Mater, where we'll be treating patients with the port delivery system, which will mean that they hopefully don't need repeat treatments maybe for 6 or 9 months. So as a result of that, and as our treatment paradigms evolve, we therefore maybe bring our patients to hospital less frequently. And this is also the case for some of the newer acting and longer acting anti-VEGF agents. And as a result of that, we need better ways of trying to monitor our patients with macular disease in the community. And this is also the case for patients who perhaps have dry age-related macular degeneration, but who we know from the data are at increased risk of developing wet macular degeneration complications. So how can we assess our patients remotely, or how can we assess them for development of reduced vision and or distortion, which may indicate that they need sooner review and treatment? We know from data collected and published from the AREDS2 study, they showed that there was certainly an evidence base for patients in terms of home monitoring. And this device called the 4C Home AMD Monitor allowed patients in, or this subgroup of patients in this cohort, to be monitored for changes in their visual function, particularly looking for development of new distortion. And by identifying those patients earlier, it meant that they were able to start on treatment for their choroidal neovascular membranes, which ultimately meant that they had better visual acuity. Because if there's one thing we know about wet macular degeneration, the sooner people start on treatment with a better visual acuity, so therefore that they're identified at an earlier stage in their disease course, the better they do longitudinally. So it really hammers home the idea that home monitoring for patients, if we can achieve that on a regular basis for those patients who we know are at high risk of developing problems that would require treatment, then this would be clearly beneficial for the patients. We're all well aware of the AMSLR grid. We all give our patients who we know are at high risk of developing wet macular degeneration, we give them an AMSLR grid to take home. And we tell them that if they notice a reduction in the vision and or distortion, that they are to seek urgent review. However, we all know from the data that patients unfortunately lose these AMSLR grids, etc. So is there something that we can kind of expect our patients to do on a more regular basis that may be more amenable to them? And this is where kind of smartphone apps come in. About 80% of us in Ireland as adults will have access to smartphones, and there's a lot of work going on to develop smartphone-based apps which may allow that kind of assessment of macular function, etc., in an effort to identify those patients who are developing problems. This is one such example, the All Eye app, And this is just the home screen from the web page. And I'm just going to show you a short little video which just shows kind of how that works. So this is kind of the home screen of the app. And you go on and you select which eye you want to test. So your right eye, your left eye, so let's say we go with the right eye. And then we have essentially the purpose of this is to get the patient to use the arrows to try to create a straight line with the 3 dots. So you move the middle dot so that it creates a straight line, and you do this over the course of 10 different tests. And that then gives an idea of it really is aiming to identify macular function and to try to identify distortion at an early time point. And it collects longitudinal data, so it builds up a background of kind of how somebody's function is. It attributes a score, and then it's really looking to see how the patient's macula is behaving relative to their past experience or their past performance. And then it has a color-coded outcome which tells you you're doing fine, you're not doing you're the same, or things are getting worse. And this may be linked with the hospitalized service, and then may be able to alert the managing clinician that this person needs to be seen, etc., for review. And Dawn Sims' group at Moorfields have done a lot of work on the use of apps and smartphone-based technologies in an effort to monitor patients with disease, and this was just a paper that was published recently, which just identified that almost 80% of eyes which produced alarms correlated with those patients who had drops in visual acuities, increases in intramacular thickness, or both. And almost 2/3 of those patients then went on to require additional treatment. And those eyes which had persistent alarms were at risk of greater loss of visual acuity. One area that that we can certainly look to aim to improve, and kind of maybe would be one of the first things that we could aim to improve. And this is there's a project that I'm aiming to pilot in my clinics at the Mater. We'll be looking at ways of collecting or ensuring that the entire data set of OCT volume scans which are required in the optician, and that those can be transferred via cloud-based referral platforms into the clinic for appropriate triage. At the moment, we all know we can get variable quality and variable amounts of clinical information at the point of referral, just because we don't have very standardized ways of requesting said information. And we're also used to getting perhaps a single line scan image from a macular OCT attached with an email referral, which means that we're missing a lot of useful information. The line scans are fine when you have a patient who has quite obvious central macular disease, but the real benefit for being able to transfer the entire macular scan would be to allow better forward triage. So with appropriate questioning and with being able to see the entire volume scan at the point of triage, then it may be that then we're able to reduce the numbers of referrals into the hospitalized service. And again, work from Dawn Sims' group, Moorfields, looking at cloud-based referral platforms, found that more than half the patients who were referred in with or who were referred with suspected macular pathology could be kept in the community without need to come into the hospitalized service. So that could have a clear benefit for aiming to create capacity within the hospitalized service, and meaning that patients don't need to make the journey into the hospitalized service unnecessarily. Finally, just to touch on very briefly, artificial intelligence has, no matter what ophthalmological conference you go to, we hear of the developments in artificial intelligence, and these will really revolutionize going forward the workload, and well, hope, I shouldn't say revolutionize, they will hopefully help us or be an additional tool that we can use to manage the workload so that our patients, again, can be managed hopefully from community, etc., without having to come into the hospitalized service. And a number of artificial intelligence algorithms have been applied, particularly in diabetic retina screening, and it's in use in Scotland, particularly useful in identifying those patients into disease and non-disease categories, and ensuring that only those patients who do have abnormalities then go on to require grading by human graders. And that will be important, particularly as the number, for example, of patients with diabetes and therefore those with diabetic retinopathy increases over the coming decades. And the HSE are, you know, providing a lot of support for innovative, innovative solutions and digital solutions in an effort to try to meet the demands of service delivery. And they've created this Living Labs setup, which really looks to kind of partner academic and private enterprise, as well as, you know, or the public hospitals in an effort to accelerate healthcare solutions. And, you know, some of the there may be some work on within the remit of this in the region of, or in the area of digital health for retinal eye disease. So I'll stop there, and if you have any questions, I'm forward to answering them.
That was truly wonderful, Tomas. I'd like to ask you a question. Do you currently have the ability to accept the dynamic OCT into your clinic in Crumlin or in the Mater?
So it's a really good question. Because of the HSE hack, we've been markedly limited in terms of accepting anything kind of digital from outside. I'm planning to run a pilot of a cloud-based referral platform, whereby, which will hopefully aim to get around that issue. So in a GDPR compliant way, a particular questionnaire can be answered and be delivered by the community optometrist, a predefined number of questions, and then the entire the fundus photo, as well as the entire OCT volume scan, will then be able to be transferred in with the link, which will go along with the health link email that we will then be able to click and then view the entire OCT macular volume scan. So that is something that we're looking to do. But to answer your question right now, no, we cannot. But that is something we're aiming to pilot.
Yeah. You know, as a comment, everything that we are endeavouring to do, even to get community referrals from one HSE institution to the other, is fraught with difficulties. And the hack has really pointed out how, you know, from a communication perspective, that we're not really in that space yet. And it is also to do with, you know, there's always an excuse about GDPR, but even separate to that, the infrastructure is not there at the moment.
I mean, yeah, that's an excellent point. I mean, the size of these files, particularly OCT macular scans, are huge, and that has been the real difficulty, and that's one of the areas that's been worked on to try to come up with a way that the scan can be condensed in a way that it is readable easily in a timely fashion in our current infrastructure. Because I suppose one of the difficulties we have, you know, I'm not sure how things are in Crumlin, but, you know, the bandwidth of our servers really is struggling with the current, you know, demands, even on a busy, you know, morning clinic. You know, there's nothing worse than you're trying to load up your OCT macular scan and compare it to last month's visit, and the system crashes. And so that's an excellent point. You know, infrastructure aside from GDPR needs to be dealt with.
Donal, you have a question?
Yeah, like it's really clearly, no matter, from Aoife's talk and Tomas is there, it's clearly, it's all about information transfer, and there's a terrible vacuum, with regard to guidance as to the way forward with the development of electronic patient medical records. And I think, well, Medisight works for ophthalmology, should really think of it as software. I think for ophthalmology, it's not really a comprehensive electronic patient record. It just can't deal with inpatient activity. But in some respects, that might be a good thing, because you could possibly sell it as a piece of software rather than EMR. They're more likely to accept it in a way than you're trying to present it as an EMR, which it isn't anyway. So you will also need a patient, a document-backed management system such as DocMan, or there are many others as well. But it's terrible that there's such lack of guidance. So everybody's going off in their own direction, and it'll be impossible to pull it together at a later stage, I think.
Aoife, you have a question there?
Yeah, I just had a question. That All Eye app looks intriguing on the telephone. When they were first looking at it, did they correlate it with OCT findings afterwards and see, did it correlate well with it, and did it correlate any better than patients' own subjective experience of reduced vision or symptoms of distortion or Amsler grid testing?
So the main correlation really was in terms of when the patients who had the alarms were then brought into the hospitalized service, and they found that those patients it was correlated really with visual acuity and OCT findings, so central retinal thickness, etc. And it was found, about more than 2/3, of those patients who had persistent alarms had increased central retinal thickness or reduced vision, increased central retinal thickness, or both. And then about 60% of those patients went on to require additional treatment. So that was, I suppose, the correlation. I'm not aware that it was correlated directly with Amsler grid per se, because this was the technology, I suppose, that they were utilizing for, I suppose, monitoring the patients.
And then just another question, coming back a little bit to what Donal was saying yesterday, given that OCT seems to be quite widely available, although it, might be in optometry practices, although it might be of the same kind of level of resolution as the hospital OCT scanners. Do you think that might be a good way again as well in the future of getting your services back out into the community and allowing patients to attend very locally, if you like, and sending in information in that way?
Oh, absolutely. That's absolutely the way forward. I mean, I would say that I feel my experience is that the reverse is true. I feel that optometry practices have as good, if not better, sometimes kit than we have access to. The newest kit and the newest software, etc. It's almost like an overwhelming amount of information that they have, and it's just to get an opinion on that. So that patients can be, stopped from coming into the community, stopped from going into the hospitalized service, I should say, appropriately maintained in the community or closer to home. And certainly there's data, coming out, particularly in the area of wet age-related macular degeneration, patients who are in the stable phase of their disease. So they've had, their acute treatments, etc. Things are stable, and then they're being monitored in the community. And there's certainly evidence from the UK that looked at kind of community optometrists and the safety and efficacy of them monitoring. And it was certainly shown that it's safe and an effective way to monitor and manage these patients. When I was in Bristol, we I suppose didn't have true community. We didn't have those broken down barriers between hospitalized service and community eye service. But one thing that was very good was that we had kind of a really good hub and spoke model. So I suppose a little bit more like where we try to repatriate patients to the community eye services. I would hope that we could mirror that. And we used to be able to deliver our anti-VEGF treatments closer to people's homes. So there were, in Bristol, for example, we had the main hub, and then we had 4 satellite units scattered around Bristol, but closer to people's home. And the patients, you know, we felt initially, oh, you know, people will feel disenfranchised if they're not coming to the hospital eye service and they're not getting the full Bristol Eye Hospital experience. But we did a survey looking at patient satisfaction with that kind of spoke model, and the single biggest determinant of patient satisfaction with the service, provided that the care was good, was, did the person who drove me to my appointment have parking? Because invariably they were asking, you know, a relative or a neighbour to bring them. And, you know, we had an outreach unit which was essentially 2 big articulated lorries in a car park of a Morrison's shopping centre, and, you know, the patients loved it. So, you know, that's hopefully what we can strive to emulate with our kind of breaking down those barriers between the hospitalized service and the community, and kind of making sure that it's a seamless flow between two. And then for this really stable patients, hopefully that we can involve our community optometrists more too.
I'm very envious of you that you're anybody working in macular disease. It seems that you have both a symptomatic condition and something so, you know, still clear, like very, you know, you can see the use of AI already, you know, kind of looking for algorithms, as you said. I think macular specialists, whatever they on whatever disease, probably have the greater level of agreement between them, really, don't they, than in glaucoma as to when the disease is actually present or absent. It looks so it's going to be much more amenable to AI.
Yes, exactly. Yeah, and even like, you know, even at the outset of their disease, you know, AI algorithms to analyze OCT angiography to try to, you know, can now kind of predict the treatment burden of that patient. So, you know, you might be able to say at the time of diagnosis, okay, you're going to likely need X number of injections over the course of year 1. And then I suppose the one thing that we've had to do in treating, let's say, patients with age-related macular degeneration is, as the treatments have evolved, we've then had to kind of evolve how we monitor our patients. So while when we used to do the loading phase and then PRN, it was, you know, the PRN, so then the patients needed monthly assessments. And now that we're into kind of more longer acting AMD treatments, maybe with the port delivery system or with the longer acting anti-VEGF agents, you know, it's not really appropriate if you think, well, this treatment will hopefully give you 6 or 9 months. We can't then be bringing you in monthly for OCT or 2 monthly for OCT. We need to be able to match our monitoring to the developments in our treatments.
Okay, listen, that's great. Thanks very much, Thomas. So I'd now like to introduce Christine Goodchild, who's going to speak to us. Christine is one of our higher surgical trainees, and I would like to welcome her to this forum. Thanks.
Thank you very much, Mr. Brosnahan and Ms. McCreery, for giving me the opportunity to present today in telemedicine in pediatric ophthalmology. I'm doing this presentation on behalf of Crumlin Eye Hospital and also Ms. McCreery. Pediatric ophthalmology and strabismus is not as, telehealth in this area is not as established as we have heard in glaucoma and medical retina, but we'll go through a few of the conditions that we can use telehealth in with pediatric ophthalmology. But before I go into that, just very, very briefly, I would like to just quickly touch on what's the difference between telemedicine and telehealth, which we use quite interchangeably. Telemedicine is mainly the provision of a traditional clinical service using electronic communication technology, whereas telehealth adds on the diagnosis, the management, and treatment of it. There's 4 domains of telehealth that we know of, and the most common one that we use is the synchronous type of telemedicine that we're well used to coming in from the COVID era, where we do a live audio video consultation with a patient, where it's real-time, bi-directional between a patient and a provider. The second type is asynchronous, which you see mainly in retinal diseases and similar things that we have heard this morning from the glaucoma and the retina talk, where you have electronic transmission of health data to a provider for evaluation and service delivery at a later date. We also have remote patient monitoring, where health data is collected directly from a patient, especially during the usual activities of daily living, such as what was mentioned earlier in the 4C or the All Eye app that Tomas was talking about. And also mobile health, which mainly incorporates the use of basically fitness trackers, cell phones, wearable technology, which is where telehealth is also venturing into. In pediatric ophthalmology, we can use telehealth in multiple conditions. The most commonly used is in post-operative strabismus patients, where we have a synchronized type of telehealth and interval amblyopia management as well. We do use that quite commonly. And things that we can also use telehealth in that hasn't been established in Ireland, but has been established in other parts of the world is retinopathy of prematurity and optic diselevations, which is a condition that we have been getting a lot of referrals for, and also for second opinions, especially if the conditions are more external. To perform good services, tele or virtual consultation, we do need good technology, as we have touched on. We need good Wi-Fi. In pediatric ophthalmology, patients need to be, not just patients, but parents more commonly need to be technologically aware. The age of the patient is also quite important, because children under the age of 3, it would be quite difficult to do a synchronous type of telemedicine consultation, because it would be unlikely for them to sit still to do, let's say, a visual acuity testing or a strabismus post-op testing. Parents will need the correct application on their device, depending on what platform is used, such as WebEx, Zoom, or Microsoft Teams. Some centers might want to do a pre-appointment setup with the IT team or the secretarial team prior to the clinical appointment. And there also has to be a platform where secure exchange and storage of data can happen, where it's GDPR compliant. And with children, you know, especially for the live video feeds, you want a fixation target for them, and also to know where the camera is actually placed. And we're all guilty of it. We tend to look at the screen more so than the camera, and it's quite important for children to be looking at the camera. So getting a fixation target is quite useful in this situation. There's a bit of paperwork involved as to how to set up the virtual consultation. Some units might want informed consent to protect the units. Some units can also use disclaimer. We have used a disclaimer as well. Or some places might want a pre-filled medical history form which you can email out to the patients and their parents prior to the consultation. This is an example of a disclaimer that we have used for our patients. And it's just to highlight that there are certain things that we cannot do in a virtual setting, such as a dilated refraction exam, a detailed motility exam, and there are situations where we have to bring the patient in for face-to-face consultation. So going into the different types of pathology or conditions that we can use telehealth in pediatric ophthalmology, the first thing is post-operative strabismus. It's mainly used in the early post-operative period, in the first 1 to 2 weeks. It's very good at picking up large misalignment if, let's say, the patient was under or overcorrected, or if there's muscle slippage. You can see the photo to the left, there is a very, very injected right eye, and it's very suspicious for an infection. And we know to bring this patient in urgently for a review. And in the patient, in the photos below, you can see they have a large exotropia on primary gaze, and on right gaze, there's a failure for the eye to adduct, and no problem with the left gaze. So we're worried about a left medial rectus slippage in that patient. As mentioned before, it's good to have a fixation target, especially in this cohort of patients. There's also an app called 9Gaze, which can be used preoperatively, but also can use postoperatively. It tells patients which way to look in all 9 positions of gaze. They composite all the 9 pictures, and you can send it on to your ophthalmologist then. So it's a good app from a screening or monitoring perspective. But for pre-op, you still need your typical measurements that you need for ocular motility. The next condition would be interval amblyopia management. The main role for telehealth in this condition would be to reduce the amount of face-to-face outpatient visits. Patients will still need to attend for their refraction. And like I mentioned, the main indication would be if they're unable to attend for a frequent in-person consultation. It's good for monitoring therapy when we're monitoring their visual acuity. And also it's great for patching, especially when parents need some additional guidance and counseling as to how to do the patches, for how long. And it's just a great way to link in with the patients without needing an outpatient visit. There are many ways to test visual acuity at home. There's many apps that one can get in the App Store. There's the Eye Handbook, which is the last thumbnail here, or the visual acuity chart. You can just get them off the Play Store. And you can change the distance in which you wish to measure the visual acuity. There are also many websites. The 2 main ones would be Safe Eyes America, where they give you detailed instructions as to what and the size of the print that you need to use for your chart and how far away to put it. And in March 2020, the AAO recommended using a tumbling E chart for children over the age of 3 years old, placed at about 3.1 meters away. So that, as you can see, there are many ways of checking visual acuity at home. The main thing is to be consistent and to use the same one at the multiple visits, just for, you know, consistency's sake, so that you're not switching between apps. So in our experience, we had about 179 patients where we had a video consultation in the 14-month period between April 2020 to August 2021. The main pathology that we were seeing would be an early post-op patient, mainly strabismus, at about 137 patients for strabismus and 1 patient for nasolacrimal duct blockage. But we also had patients for interval strabismus monitoring, and also for second opinions and for initial consultation for life or sight-threatening diseases. Another condition that lends itself very well to telehealth is like lid cysts and tear duct pathology as well. And in our cohort of patients, only about 18% of them were unable to perform visual acuity testing. And I think, you know, especially for pediatric ophthalmology, the home visual acuity testing is a big concern for a lot of healthcare providers in regards to their reliability. And it's very good to see in outpatient cohort, only 18% of them were unable to do so. And in addition, only 10% of our patients had IT issues. So 90% of our patients were able to complete their virtual consultation successfully. And I will move on to, you know, conditions that we can use telehealth in Ireland, which have been used in other parts of the world, especially retinopathy of prematurity, which Tomas very briefly touched on earlier on. You basically need fundal imaging, and the most common way of getting those imaging would be through a RetCam or PanoCam that we have in different units. And these images can be sent to a experienced ROP ophthalmologist. It aids diagnosis in a very time-sensitive manner, and also it reduces the need to transfer a lot of these very fragile preterm babies to central units in Dublin for second opinions, let's say. There are multiple evidence out there for RP screening in the telemedicine capacity. There is the KIT-ROT trial, which was done in India using RetCam images, and it showed that, and a lot of these are done with technicians reporting on the imaging, and then it's then compared to the expert opinions of the agreed upon imaging status. So there's technician agreement of 94.3% and a very high sensitivity and specificity. And in the KINROP trial, about 0.4% of patients needing treatment were missed. So there's a low amount in that study. The SUNDROP study is done by the Stanford University crowd, and they had even higher sensitivity, specificity, positive and negative predictive values, especially for treatment-warranted ROP. And the EROP cooperative group has published multiple papers in this regard, and it's across 12 clinical sites in the US and Canada. And what they show is that, you know, with non-physician trained readers, they're able to get a very high inter and intra-grader reliability as to what diseases need to be referred on, so referral warranted ROP. And they also showed that you need five good images to be able to get good sensitivity and specificity in terms of diagnosing retinopathy of prematurity. And they have extra data as to, you know, patients who would progress from pre-plus to plus, and also for plus disease, the sensitivity and specificity of using this form of technology and how it would progress. And it tends to happen in bilaterally, especially in superior and inferior temporal quadrants. So there's a lot of data out there for using telehealth in retinopathy and prematurity, which lends itself very, very well to this forum. And I think Tomas showed one picture there, show a few more pictures of ROP. These pictures are pictures of patients with threshold ROP. In pictures A and B, you can see that they have stage 3 ROP in posterior zone 2 with some plus disease. You can really appreciate the plus disease with the tortuosity of the blood vessels. Similarly, it's more obvious in pictures C and D, where they have associated hemorrhages in those areas of neovascularization. And those images are very, very obvious that these patients will need treatment. So it does lend itself very well. Aside from diagnosing, it's also very good for monitoring purposes. You can see patients before and after their treatment with laser photocoagulation, especially in the pictures C and D. You can see that after treatment, the neovascularization towards the ridge it has really regressed, and the plus disease as well has also regressed. So you can see that this does lend itself very well. And optic diselevation, this is relatively new. There's very little literature out there about it, but we are getting quite a few referrals for patients who have optic diselevations, especially when they've been picked up by the optometrists or the opticians in the community. And as Tomas mentioned earlier, they do have far superior imaging equipment compared to us. So they do pick up a lot of pathology in that setting. So it would be a great avenue to look into in the future for telehealth, because it will aid us in terms of a pathway for referral to see which patients are more urgent than others, because we do see a mix of patients who would need very urgent referrals for scans versus patients who may not need interventions at all. So like in these pictures, especially the fundal photo, you can see that in this fundal photo, we are we should be very concerned about this patient, particularly because of the tortuosity of the blood vessels, the hemorrhages at the disc. And it's actually a picture from a patient with known papilledema. And in this OCT, which is a different patient, you can also be very suspicious of the optic diselevation in this patient, and try to act in a more timely manner. It's also a great way to link in with our new community ophthalmic services, especially after a serious pathology has been outruled. So as contrast, you can, if you do get pictures of a patient such as this, where it's more likely to be optic dysdrusen, you're not as worried. Especially in the frontal or the disc photos, you can see those drusens sort of extruding from the optic nerve. And if you're fortunate enough to have to get an autofluorescence, you can see that they do fluoresce quite nicely. And even in the OCT single cut images, you can see they're more, in keeping with optic dysdrusen than a papilledema. So you're able to triage these patients a little bit better, especially with the limited resources that we have at the moment. And lastly, second opinions. We can use telehealth, especially in situations where patients have been seen by another ophthalmologist, let's say in the peripheral unit, and would require a second opinion by a pediatric ophthalmologist. The pathology that it lends itself quite well to is sort of ptosis, nasolacrimal duct blockage, cysts and cataracts. Certain patients will need a confirmatory exam at either in a clinic or as an EUA. Some things can be listed directly from the referrer after a detailed video consultation pre-op. And it's just a very useful platform to use when patients live very far away or there are COVID restrictions in place. There's also, digital slit lamp videos that we could use to send on images to another ophthalmologist. And it has very good inter-reader agreement, especially for things like conjunctival, scleral, anterior chamber iris pathology. So it's a great way to link peripheral units and central units, community units, and also, tertiary units. And just quickly in conclusion, we mainly use telehealth in pediatric ophthalmology at the moment for post-operative strabismus and interval amblyopia management. There's very strong evidence for using it in ROP screening, which we should be looking into. It's a very effective way of providing a service for our patients. It's quicker, but it does need a huge investment in technology. And there's a potential use for it in optic diselevations in the sparse literature at the moment, but it's a new and exciting avenue that we can look into. Thank you very much.
Thank you so much, Christine. That was a lovely overview of the potential uses. And in fact, we have incorporated post-operative strabismus WebEx consultations in the clinic in Crumlin. But I'd like to open the questions to, with regards to the ROP aspect of things. Does anyone have any questions or comments? I think, to be honest with you, this to me is the way forward with ROP, simply because we're lucky in Ireland in that we do have screeners that are physicians, but in countries that don't have the capacity to have physicians do all the screening, this is really important to have non-physician graders evaluate patients and send their images in for assessment. And this is definitely going to become the norm in, certainly it's already the norm in parts of India, but I think in peripheral units, and especially with very tiny babies, the way neonatal care is in Ireland is at the moment is that they go to the peripheral unit, and bringing them back and forth from, say, Portlaoise or Cavan that occasionally may not have ROP support really is proposes a lot of difficulty, and including that, a lot of cost to the neonatal service. So I think it's from a pediatric ophthalmology perspective, this is definitely going to become mainstream in the next couple of years. Do any of the panelists have any other comments?
Yeah, I just had a question there for partly for Christine, and then partly Donal might know the answer to this as well. In terms of virtual kind of, telephone consultations. I suppose one is, Christine will know this from experience on that very good study, like, do they take longer or the same time as ordinary consultations? And given that we now have the challenge of large numbers of patients waiting to be seen, do you think we're going to be able to continue this in the long term? And is there a way in each of the hospitals of recording it as activity, so the patients actually from the virtual consultations are listed on the total numbers of patients seen for when we're kind of returning our figures for activity at the end of the year?
I know in the...
Yeah. Sorry, Christine, you go ahead. Yeah.
I just know in terms of patient numbers, I know in the MATA, in the ED department, when we do virtual consultations, it is counted and patients are logged as being seen, but they do specify it's virtually. So it does count into the numbers that have been seen through the emergency department in the MATA. And in our outpatient in Crumlin, when we do the video consultations, they are also part of the clinic. Yeah.
Does it take longer or about the same time, would you say?
For the video consultations for the post-op, I think it takes about the same time, to be honest, because a lot of the setup is done by the secretaries. So they have, let's say, 3 patients who had their surgery, let's say 5 days ago. They have them all line up, and to me, it takes about the same time. Yeah, but obviously, depending on patients as well, sometimes they might have issues with, IT issues. But again, I think much the same.
And you allocate one staff member from the clinic to that for the course of a clinic. Is that the way it works? Yeah.
Well, for the post-op squints, because usually there's only about 3 of them, so you will do them in half an hour. Yeah.
Just add that we are submitting data on virtual consultations, and I think it was around 14,000 last year, actually. So it is significant activity.
Okay, well, we'll conclude the session, and thank you so much to all of the speakers today. It's amazing how much you learn, and thank you to you all. And we will bring this session to a conclusion. Thank you.